So I was just saying, if you missed last month's seminar, it was number 1. This is number 2. Our goal is really just to educate women about hormones, to keep everybody abreast of the latest science, the latest information, and allow you all an opportunity just in a relaxed setting with other women to ask questions and continue to learn about this world of hormone replacement therapy, because it can be confusing, it can be scary, and we've talked about, before tonight that it's really an individual journey for each woman. And so tonight what I really want to focus on is forms of hormone replacement therapy, because once we have that foundation, there's so many questions about, well, how do I take this? Do I take it orally? Do I use a cream? There's these things called ready tabs. So I want to talk about that and some pros and cons of each of the different forms. And then I really want to get into the science too, where we're differentiating between what the Women's Health Initiative study proved, what that science is showing, and differentiate that and compare it to the bioidenticals and what the research and science is showing about those, because I think that that's where a lot of the confusion comes from. So I think the most important thing to understand, and this really addresses again the Women's Health Initiative study, is that we've always referred to synthetic hormones, which are actually drugs or medications, as hormone replacement therapy. And the reality is they were never hormone replacement therapy. They were actually hormone substitution therapy. And so really beginning to wrap our brain around the difference between those two things becomes a really important point. That is what the entire Women's Health Initiative study was all about. It was about these drugs and the substitution of drugs for hormones and what the actual effect of that would be in the female body. So when we talk about hormone replacement therapy, what I really want you to think about tonight is what we're trying to accomplish is putting something back in the body which is molecularly identical to what was there originally. And that becomes very important because hormones are like a key. They fit in a cell, an organ system, and a lock that's specifically designed for them. And just like the key in your house, it's got to be exact for that lock in order to actually open that door and make certain things happen. It's interesting. I come from the traditional medical model. I'm a medical doctor. I started off as an ER doctor, ER physician, ER director. And so I'm very familiar with the world of drugs and interventions in traditional medicine. I think it's an amazing science. I support it for what it does, but it's a very different philosophy than what we're doing with bioidenticals, because what we're really trying to do with bioidenticals is we're trying to reproduce nature, as opposed to some extent, we've looked at menopause or perimenopause as almost a disease process, right? And diseases get treated with drugs, right? And so that's really how we approach this physicians up until the world of bioidenticals. So hormone substitution therapy. Yes, it can relieve symptoms, but just like medications, because they're not bioidentical and original to the body, they're going to have a lot of other side effects, issues, good and bad, that happen in the body. And so we really want to begin to distinguish between those things. You're going to see tonight the safety profiles of the bioidenticals versus hormone substitution therapy is very different. And I think you're going to see tonight too, and I was surprised how much more research has really come out. But when you're looking at the bioidenticals, what you're going to find is that they tend to be more effective, they're safer, and they really have fewer side effects. And thinking about nature versus drugs, when our hormones are balanced in the natural female body, we don't have symptoms, issues, or problems, right? We feel good and we feel balanced, and that's really what we're trying to accomplish. So this was really interesting to me. I forgot that we're actually given millions of eggs in our ovaries, and of course we produce one of those eggs during the reproductive years through this process called ovulation, but we do 1 egg, 2 eggs potentially every month. So what happens to the rest of those millions of eggs? Well, they're lost through this process called atresia. And the reason that we care about that is atresia is the loss or aging of eggs, and that's how we lose most of our eggs. And what that means is that as we move into perimenopause and menopause, and all those eggs are lost, if we're trying to ovulate an egg that's old or, I'll call it atretic, I'm going to make up a new word, what we'll find is that is what's going to happen with this whole picture that we have. Come on in, hon, and there's food and things up front if you want something.
Okay.
But if you try to ovulate an egg that is old or dying, you're going to have an anovulatory period, and as a result of it, you're not going to make the hormones that create the balance that's so important for hormonal balance in the perimenopausal and menopausal years. And essentially, menopause means that you've completely lost all of your vital, healthy eggs, right? And now there's actually no hormone production that's happening at all through the process of, the luteal phase and the early phase of the cycles. So perimenopause becomes a very important stage for women because we have these anovulatory cycles. And as a result, when you don't ovulate, the first thing that happens is you lose progesterone. And you're going to see how important progesterone is. But progesterone is critical to balance estrogen. When we lose it, it really sets women up for not feeling good. And a lot of these things that we're seeing in the 40 and 50-year-old female, for instance, fibrocystic breast disease, breast cancer risk, we're seeing ovarian cysts, we're seeing fibroids in the uterus, we're seeing all sorts of different things that women begin to experience, and obviously we don't want to have any of those things. And this is the other important point. Sometimes I think our physicians say, well, just get through perimenopause or get through menopause, maybe it doesn't, it's not going to last that long and things are going to go away. We've talked about that tonight too. But even perimenopause can last from months to 10 years. That's a long period of time. And every woman is different in terms of how long that process actually takes, for her to go from some ovulatory, some anovulatory cycles in perimenopause into menopause where she's not ovulating at all. So what happens with the hormonal shifts? Well, a lot. So they lead to physical, mental, and emotional imbalances. And that's probably the number one thing I see with women is just that I don't feel good, I can't sleep, I'm anxious. Besides the classic things that we think about, like hot flashes, night sweats, and vaginal dryness, and so on and so forth.
And they're called adult onset of ADD.
Yeah, I have some women that literally say to me, I was fine until something happened, and now I can't form a sentence. I'm a lawyer, I can't go into a courtroom and try my case. I can't, function as a physician and communicate. I can't remember my best friend's name, and it really is. It becomes a real focus issue and a memory issue. And so typically when you go to your physician, you're going to get your FSH checked, right? And that's kind of like, okay, if it's over a certain level, now you're officially diagnosed with menopause. But what was interesting to me too is that as we look at the actual screening things for menopause, and the classic definition is an FSH over 50 and no cycle for a year, that's actually one of the most unreliable measurements of being in the menopausal state. And again, I think the importance is to constantly monitor and work with women through the perimenopausal and menopausal period to actually create balance, because that's how you're going to feel good.
What's the FSH again?
So it stands for follicle stimulating hormone. So it's actually stimulating that that ovulatory process. It's the thing that stimulates the follicular phase. But that's what we typically screen for. So goals for tonight are to look at Promin and Provera, the synthetic hormones, what they did, why they're different than bioidenticals. We want to compare them to the bioidenticals. We want to look at routes of delivery and the effects, like how would I make the decision to do one thing versus the other. And this is really interesting to me too. And I've talked about this for a long time, but it's actually in the literature now. What about this small group of women who actually enter menopause and don't have any symptoms? Have you all met any of those?
Yeah.
I see them occasionally, but it's a very small group of women.
It's because we killed them.
Good point. The interesting thing is that the reason that they don't have symptoms is because in the postmenopausal woman, we're designed for our adrenal glands, which are our stress organs, to actually kick in and make all the hormones that our ovaries did previously. Unfortunately, our adrenal glands are also our stress glands, and because we live in a modern world and there's so much stress and multitasking and traffic and financial pieces and families and kids and jobs and husbands or spouses or partners or whatever, it's very hard to enter menopause with a healthy adrenal system that actually allows that hormone replacement to be taken up by that organ system. It's much more common in the Asian countries to have healthy adrenal glands, and that's why more Asian women actually don't have menopausal symptoms, along with other things like iodine levels and so on and so forth. So I've already made this point, but I really want you to wrap your brains around the fact that it's vital for women to measure hormones through all stages of life. It's not something that you should just begin to do when you hit menopause. And in the ideal world, we would actually look at hormone levels for each woman at a young age. So when a woman's cycling, I'm looking at her estrogen on day 12, her progesterone on day 28, because that's when they're hitting peaks. Why would I care about that in the menopausal woman, that same woman? Because that's what I'm trying to reproduce. I'm trying to reproduce her hormonal balance. So if you know what it looks like early and young, you can follow that woman throughout life and actually reproduce that in her body. So you're trying to reproduce her natural hormonal balance. Estrogen must be balanced with progesterone. So this was another one of these kind of big mistakes that we made. These hormones go together, they're partners, they're designed to balance each other. Estrogen is what I call proliferative, so it creates growth, and uncontrolled growth in the body is not a good thing. Progesterone is about growth regulation, so it controls that growth, it tells it when to continue, when to stop, and so those things really have to go together for protection. If you don't balance them, what are you going to get? Fibrocystic breast disease, breast proliferation, which is breast cancer risk. And I see so much of this now in the 40s and 50s women, and again, it's typically because she's maintained those estrogen levels, but the progesterone levels have fallen off, and that's not a good, healthy state for a woman to be in perimenopausally, especially for 6 months to 10 years, right? It can be going on for a really long period of time. In the young woman, when we see women with premenstrual symptoms, what they're actually experiencing is a lot of estrogen and not enough progesterone. And some of us, if we have, teenage daughters, will actually, see young women experiencing this. And in my world, it's very important to allow them to be in hormonal balance too, because it really affects the quality of their life. In fact, now we have medications like Prozac that we give for PMS, right? It doesn't fix the underlying hormonal issue, but it takes that edge and irritability and so on and so forth off, so that they can actually experience a better quality of life. Perimenopause, we talked about this. Classic picture is progesterone falls. Now we have growth of the endometrium, of the lining of the uterus with estrogen, so we get heavy bleeding and clot and irregularity and all those things. Same thing, estrogen, no progesterone. In the menopausal woman, sometimes she'll finally get some relief because those estrogen levels fall off with the progesterone. Now she's in a low hormone state, but at least it's not estrogen dominance or estrogen, excess with progesterone deficiency. And this is the big mistake that we made up until, you'll see in the next slide, I think it was 2006. But if you had a uterus and you were taking estrogen, it created proliferation, growth of that lining, and that ultimately gave you uterine cancer unless you actually balanced it with progesterone. And the administration of progesterone, synthetic progesterone with synthetic estrogen, was really specifically about addressing the endometrial cancer that women experienced when they were taking estrogen by itself. But we're going to see how important it actually is for all other tissues of the body. So here we are, big Women Health Initiative study. This is when the whole hormonal world changed. I had began doing hormones in 2000. When this study came out, I was like, oh my gosh, we're going to actually tell the truth, about what we've been giving to women. So 16,000 women or so, 50 to 79 years. And what we found is, oh my gosh, the benefits don't outweigh the risks. In fact, we see more breast cancer, more heart attacks, more stroke, more blood clots. And they said, well, we do have to admit that you see less hip fractures, less colorectal cancer, And yeah, it does relieve menopausal symptoms, which we already knew, but we can no longer say that the benefits outweigh the risks. And so all of a sudden, all of these women that had been on Primpro, Premarin, Provera, synthetic hormones got pulled off of these hormones, and it was really kind of a whole new world in the world of hormone replacement therapy for women. At this point, I had been doing hormones for 6 years. It changed my practice 0% because we weren't doing any synthetic hormones. We just moved right ahead with the bioidentical hormones. But I think to some extent too, there's been even more confusion since this study because this stuff is scary. And women are trying to sort through, well, is this all estrogen? Is it all progesterones? You know, which specific forms, you know, which specific ones are creating issues? And that's where a lot of the problems actually come from. So side effects of synthetic hormones. And you know, this is the synthetics again, but what did women experience? Well, some of them did great in terms of relief of symptoms. Some of them had relief of symptoms and came in with serious issues like breast cancer or clotting risks. But a lot of them also had weight gain, bloating, breast tenderness, and irregular bleeding, and they just weren't happy with that, so they stopped taking hormones. This huge fear of cancer, you know, was present, especially after the Women's Health Initiative study. When I got into the world of hormones, I think I saw 6 women in 1 month, all on less than 6 months of hormone replacement therapy, all with a diagnosis of breast cancer. And my question just became, what are we doing? What is going on here that really needs to be addressed at a deeper level? And then, you know, certainly after the Women's Health Initiative study, a lot of physicians just said, you know what, we're not going to prescribe this anymore. The benefits don't outweigh the risks. We're going to pull you off. So I don't know if you all remember this, but this is equally important, you know, to women in their brain. But following the Women's Health Initiative study, there was actually a study on what happens with memory with synthetic hormones, and they found that women do worse on synthetic hormones, and there's actually a higher risk, excuse me, of dementia. And so, obviously, too, you know, these are things that none of us want to experience. So, what I want to do now is really look at the side effects of synthetic hormones, compare them to the bioidenticals. I want you to conceptualize that Premarin actually has about 100 different estrogens in it. When we consider doing hormone replacement therapy with women, we're thinking about 3. I typically give 1 that creates all the benefits. And the issue is that those hundreds of estrogens in Premarin were really where we saw side effects and issues and problems because they weren't innate to the body and we weren't reproducing nature. You're going to see that synthetic hormones lead to all sorts of more estrogenic side effects. So all that stuff we talked about, not only disease, but the bloating and the fluid retention and all these different things that women don't like. And certainly, you know, breast cancer, fibrocystic breast disease, clotting risk, all that stuff is there with the synthetic hormones. The bioidenticals, differences in action, risk, and benefits. The interesting thing, and again, as part of doing this series, I had a chance to go back and look at the literature. There is not a 16,000 woman study on bioidenticals, but there's lots of small, significant studies that are out there now. And reviewing those, I mean, there's no doubt that there is, in these studies, there is no increased risk of clots, breast cancer, heart disease, or cognitive decline if you're using the bioidenticals. I mean, so, you know, I always want to be honest with women. I want to tell you all the good, all the bad, all the everything so that you can make your choices. But I was really impressed with the amount of literature that is out there now on bioidenticals and their safety profile. So this is a slide that you can't really see, but again, I'm happy to send this to you. But it goes through natural estrogen, synthetic estrogen, all the different names for natural estrogen, all the different names for synthetic estrogens. The reason that this is important is that after the Women's Health Initiative study, there wasn't a lot in the marketplace with commercially available bioidenticals. There is now. You know, people talk about not being able to patent the bioidenticals. That is true. You can't patent a natural substance, but you can patent a delivery system. So now we see in terms of some of these gels and patches, there actually are natural products out there in the marketplace. And so I think it's important to distinguish, you know, whether it be compounded or commercially available, you know, you're getting it through your compounding pharmacy. How do I differentiate what is innate to my body and natural and what's different? We know that Primarin, as I mentioned, is made from horse's urine. It has 100 distinct estrogens, and you know, very few of those were actually natural and innate to the body. So I've talked a lot about this last time, and if you take away one thing tonight, and I want to say this a couple times, the key to hormones: right form, right level, right balance. If you do those things, I think that you're going to see that the benefits and the risks, you know, the benefits are huge, the risks are minimal, and the improvement in quality of life with women is really substantial. So, which form should each woman use? The first thing I ask a woman is, what form are you inclined to use? Because the reality is, if I give you a form that you don't like, you know, I'm giving it to you orally and you really feel strongly about creams. I'm giving you creams and you travel all the time, so it's hard to travel with. If you don't take it, you're not going to get the right level and you're not going to have the right balance. So I really want to know from each woman, what do you want to take? Because in the end, different forms do different things in different women's bodies. And you're going to know that in my practice, because we're going to measure the levels and we're going to know for sure that you've hit those safe and effective levels. But I want you to have something that feels consistent with really what you want to do. And I want to tell you too, you know, what's the pros and cons of different forms, so that you don't do anything that's going to be unsafe or not in the best interest of your health. But with these different forms, there's oral, taken by mouth. There's transdermal, so that means through the skin. So there's going to be patches, there's going to be creams, there's going to be gels. There's actually intramuscular, where you're doing an injection of different hormones. There's subcutaneous, and it's interesting because pellets were really popular in like the 40s and 50s. They kind of went out of vogue. They're back in vogue right now, so I want to talk about the pros and cons in my experience with pellet therapy. There's sublingual, which means under the tongue, so we'll talk about that different form. There's vaginal. I mainly see that with women who are pregnant and they have progesterone deficiencies, and we're trying to really raise those levels to protect that pregnancy. And there's actually nasal forms of hormones too, and we'll talk a little bit about, well, why in the world would you do that? So, oral bioidentical estrogen. So, kind of pros and cons there. Interestingly, when you take oral estrogen, because it's metabolized with what we call first pass in the liver, it actually has more beneficial effects on your cholesterol profile, because a lot of that cholesterol production is actually controlled in the liver. So with a woman with a non-desirable cholesterol profile, I may actually give her oral estrogen. There's some science on it worsening triglyceride levels, which are an equally important risk factor for heart disease, but I'm always following that and knowing that. So in my practice, if you have high cholesterol, if you have high triglyceride levels, we may be talking about oral estrogen, but we're going to be talking about it in conjunction with measuring your cholesterol, your LDL, your triglyceride levels, and seeing what the before and after actually is of oral estrogen. But we do know, and right now I'm going to be talking about all bioidenticals, okay? So the synthetics we're done talking about those for tonight. So there actually is more clotting risk with bioidentical estrogen. And so if I have a woman that has a family history of clotting risk, we do a lot of genetic testing in my practice, so if you have something in your genetics that makes you predisposed to that, we're going to actually know that, and we're going to actually make recommendations to protect you in terms of risk. Because of this first pass effect, where you take it and it's metabolized in the liver before it actually gets into your bloodstream, you actually typically will require higher doses of oral estrogen than you would if you took it in other ways. So when you go through the skin, this transdermal way, we're talking about estrogen cream. So now we're not getting the first pass through the liver, so we can do lower dosages. There is a lower clotting risk when you do transdermal estrogen. You're going to see that also with ready tabs and troches. So as long as you're not taking it orally and swallowing it, the risk of clotting goes down. I mean, actually there is no risk of clotting, right? Let's gallbladder issues. Yes?
So when you're talking about an estrogen cream, is that an estrogen progesterone mix?
It's not. Right now, I just want to talk about estrogen and what we know about that, and then we'll talk about progesterone,
Okay.
how you can take that, and if you have questions too about can they be put together and things, we'll talk about, you know, what that really means too. That's a good question. Remind me to come back to that. Gallbladder issues, there's some research that says if you take oral estrogen, it may promote more gallbladder issues. I've never had a gallbladder issue with any patient I've ever given any form of estrogen with, but I think it's worth considering, right? So less gallbladder issues if you're going through the skin transdermally, not orally, so, you know, sublingually, any other form than oral. We always have to consider, is this person going to absorb estrogen well through their skin? Again, in my practice, we're not going to wonder, you're going to know, because we're going to actually measure levels and see how you're doing with that form. You know, are you hitting these target levels? So again, right form, right level, right balance, right? Difficult to travel with, you know, now with air transportation being the way it is, a lot of times we're doing a carry-on, right? It's hard to put in a carry-on because it's cream, you know, so I always consider that in terms of lifestyle pieces for women.
If it's got a prescription on it, it's easy.
And I, you know, again, yes and no. I mean, it's, you know, a lot of people just want to breeze through. Yeah, and so it's just, you know, I think women too, like, if they end up taking it for whatever reason and you're without your hormones and you get there, it could be an unhappy arrival, shall
No,
we
I'm
say.
saying if you have a prescription, they will not take it away from you.
Yeah,
But it has to be on the bottle.
yeah. So, you know, I think that's just a consideration too. So the last thing too is it's interesting, and you know, Ashley and the pharmacies, you know this is more in their science than actually my science, but there's different forms of even the creams, you know, the liposomal base, the gel base, so on and so forth, and different people's bodies and different skin absorbs things differently, and so that's worth considering too as you work with your physician, your pharmacist. Again, you're not going to have to wonder about that if you decide to go through the skin, because you're going to know based on blood levels, or at least you should know. I do see women that have no idea, you know, they're on bioidenticals, but they have no idea what their level actually is. Estrogen patch is another way to give it through the skin. Some of the pros and cons there, you know, so now it's on your skin, and instead of kind of having that peak and valley that you get with estrogen cream, you know, it's absorbed and then it kind of reaches a steady state and absorbed with application and, you know, reaches a steady state. With the patch, you're continuously delivering kind of the same amount through the skin, maybe more physiologic, like the body actually makes it. Sometimes there's like a twice a week patch. I think there's even once a week patches. So that might be easier for some women. They just put it on every Sunday or Monday or whatever day they pick. So that could be easier. Again, it's a lower dose than oral because there's not this first pass through the liver, like when you take it orally. And some women, again, just through lifestyle pieces, they like to put lotion all over their body. If you try to put a patch over a lotioned area, it doesn't stick so well. They exercise, it comes off. And so some women, again, it's just not consistent with their lifestyle pieces. Okay, so sublingual now, under the tongue. You can actually do this. I'm fond of these. I use these all the time. They're little round things about the size of a sweetheart. They're made by the compounding pharmacy and just the right dose for you. You put whatever form of estrogen in them, you know, put whatever form of progesterone or testosterone into them. They go between the cheek and the gum. They dissolve into that vascular, highly vascular tissue in your mouth. They're not to be swallowed, although you may get a little bit of, you know, oral, you know, swallowing of it. But they're made to actually absorb in that vascular tissue inside of the mouth. And there's another form called troches that are kind of more gummy. They're kind of an older version of Ready Tabs, and I tend to use the Ready Tabs frequently. So no first pass, lower dosages. Again, some women will not absorb in this way. In my practice, you're going to know because you're going to actually measure those levels. They're easy to travel with, you know, because they're not, so you just throw in things and, you know, no one's going to stop you on those. Some women really don't like the taste, especially with progesterone, which we'll talk about in a minute, because you have to use relatively high amounts of progesterone, which has a bitter taste, and so that's a real issue for some women. Intramuscular, so injections, subcutaneous, pellets, vaginal, like you're actually inserting it vaginally, nasal. So obviously, intramuscular, vaginal, nasal, I just don't really use those. They're not, you know, patient friendly. And so most women are not going to want to do that, which is that first rule, you know, honor what the person's going to actually do so they can hit those levels and create the balance that you need. This is something that I learned, and so you can actually use this nasal spray for people with eustachian tube dysfunction. And some women, you know, menopausally, because every woman's journey, every person's, you know, postmenopausal picture is different. They can actually get heart beating in their ears, they can hear their voice in their ears, they can get fluid accumulation in their ears. Interestingly, intranasal estrogen can actually help with that. And then the last thing on pellets, and I kind of mentioned this before, popular.
Does it help with tendinitis?
It can. It can help with tinnitus.
Huh,
So,
okay.
yeah, you know, I mean, so that's, you know, certainly, you know, tinnitus is that kind of chronic ringing in your ears. You would think, oh, it's just a little ringing in my ears, but people who have it, it's really, really annoying. Yeah, and so again, if they can be helped with intranasal estrogen, it's kind of an interesting use of hormones. Pellets, again, popular 40s and 50s, went out of style, have really come back into style again. The first exposure that I had to pellets was all through women who were having a lot of issues relative to pellet insertion. And so this is the thing on pellets. If you put a pellet in and they say that they last about 6 months, my experience is that they last about 3 months. If you put them in and you get it right, you're good, right? Because you can do the bioidenticals, you've got it done as long as it doesn't bother you to come in and do this little minor surgical thing to get it, to actually get it put in, and typically it's going to go in, you know, the buttocks or a love handle. The problem is, if you get it wrong, these women will have extraordinarily high estrogen levels. And so they feel horrible, and there's nothing that you can do besides write it out. And so I've seen women way outside of 6 months that are still having excess estrogen symptoms related to a pellet administration, and it's a miserable experience. So, you know, they've kind of revamped pellets and so on and so forth. I've used some of them in my practice just to kind of study and research them, and there is estrogen, progesterone, and testosterone pellets. Because I've seen so much heartache over too high a levels, I think you always have to be conservative, and so the downside of that is that if you underdose, then you've inserted the pellet, you still have a woman that's low with estrogen, progesterone, testosterone, and now you're still talking about ready tabs or cream or some other form to bring those levels up. So I personally am not a fan of pellets because I think it's so hard to get it just right. Having said that, if you're a woman and you're using pellets and you're bioidentical and your levels are measured and your hormones are balanced, it's all about getting it right for you. So I think those are kind of the pros and cons there. Natural versus synthetic progesterone. So a lot of confusion here. So remember with the Women's Health Initiative study, progesterone made things worse, right? Well, again, what they were talking about is synthetic progesterone. You know, there's progestins, there's progestogens, there's all sorts of different forms of progesterone, and the issue is they all got combined, and we were told that they were all the same, when in fact they're very different. So where do these hormones come from? Well, this is another point of confusion for women. So they come from soy or yams. So we have a precursor molecule that's taken and extracted by a company. It's sent to a biochemistry company who actually converts that molecule into something that's bioidentical with the body. Okay? That now is given to the compounding pharmacy, and now that can be compounded for you in the correct dose in the way that you want it delivered. But can you just substitute soy or wild yam cream and have it do the same? You can't, okay? Because that chemical conversion process does not happen. So you're not going to get the same things with soy or yam cream or soy or yams that you will with bioidentical hormones. So that's this point. And then what about over-the-counter progesterone cream? Because we know that that exists too. You know, again, you cannot get high enough dosages. You know, and again, if you can, that's great. but you really typically cannot get high enough dosages of progesterone and over-the-counter cream to actually get your levels up and provide the protection that you need. So that's just, again, what I see over and over again with these different things. And again, I think there's confusion. You know, if I have low progesterone, can I just, you know, run to the store and grab some progesterone cream over the counter? Nope. Can I do soy or yam cream? Nope. Typically, you really just can't do those things. Same thing here. This is a chart of synthetic and natural progesterone. Important to know these names. Again, if you all want this, happy to give it to you because I think it's important to say, you know, this is bioidentically mimicking exactly what the body needs, and this particular substance is it, and there's a lot of different products.
When you say bioidentical, can I infer that it's a